Hello, good evening, and welcome to all the delegates that have joined us for today's webinar. We, the team Cynodent, bring you up this today's webinar. Cynodent is a unique platform for the first time in India, a digital healthcare platform that provides and enhances a good relationship between patients and the doctors and also enables a real-time appointment system and scheduling system. Our goal to create easy access to healthcare services and communication ways or appointment scheduling, not only between the dentist and the patients, but also between the patients and the medical practitioners, pharmaceutical services and radiological services, and also research and educational programs for doctors to enhance their knowledge and keep them updated regarding the same. Cynodent bring together at economic prices and minimum waiting time because everyone has 24 hours and we have to utilize it without wasting it. So Cynodent is here to create precious smiles on faces of a patient with minimum effort and maximum welfare. Cynodent is an initiative that will put up all its efforts to create beautiful smiles, and our patients now do not have to fear long queues and the busy dentist when they get a toothache. So good evening to all the delegates. Myself, Dr. Prateek Bam. I am a second year postgraduate student from the Department of Prosthodontics, Tirthankar Mahavir Dental College, Moradabad. I am co-hosting this session with Dr. Shweta Tiwari. She is the president head of Chandra Dental College, Team Cynodent. Along with us, we have Dr. Anmol Bagadia with us, who is a founder and CEO of our team Cynodent. So coming up to today's webinar, we have Dr. SURABHI MAHIDHAR with us. Dr. SURABHI MAHIDHAR, a name that needs no introduction. But still, Dr. SURABHI MAHIDHAR, sir, is a maxillofacial prosthetist from JSS Dental College. He has passed out his undergraduation and post-graduation from JSS Dental College, Mysore. He is into clinical practice after his post-graduation from 2008, and he has been lecturing, taking workshops and hands-on all over India on various aspects of FPD, FMR, complete denture, and implant prosthodontics. He is the recipient of fellowship and mastership in surgical prosthetic implantology from Implant Study Group, Bengaluru. He has been conferred with various awards like Outstanding Dentist and Best Prosthodontist of the Year at various platforms, including the FAMDent Awards, the Indian Dental Health Professional Awards, and in the Indian Health Professional Awards. So on behalf of the complete Cynodent team, sir, we welcome you for our today's webinar. Dr. SURABHI MAHIDHAR, sir, over to you.
Thank you. So today we are here to speak about one of the most important aspects of full mouth rehab, the anterior guidance. Thank you guys for the lovely introduction, and best wishes to all of you here who have been a wonderful team and working on it. So let's start with the session.
Yes, sir.
Yeah. So when it comes to anterior guidance, the first and foremost aspect that I need to talk about is the 5 important things that we need to consider when it comes to the wax-up stage of full mouth rehab. The various steps when it comes to the full mouth rehab, right from the history to the final processes, we have a lot of steps that go in sync, A to Z of full mouth rehab. But when it comes to the anterior guidance especially, the first thing what we need to think about is the whole stomatognathic system as such in toto. So when you see this picture, you will understand that there are various aspects that are involved in the system. You have a joint that is involved, you have a muscle which is involved, and you have teeth that are there inside the sockets that are involved in the stomatognathic system. If these three things work together in a sequence, then yes, whatever rehabilitation has been done inside the oral cavity would get some balance. Then we say that the whole system is equilibrated. If we don't take the joint and the muscle, and if we just start with the teeth inside the sockets, if we start putting the restorations, if we start placing any kind of changes over the teeth, in the sockets inside the oral cavity without respecting the joint and the muscle, then it would not be called as equilibration, in simple words. So if you see, there is something which is known as Hanau squint, okay, in prosthodontics. The Hanau squint targets few things. When it comes to the first thing, it's a joint. What is happening in the joint is the first aspect of Hanau squint. What is happening in the joint, basically? So when you take the temporomandibular joint, it's the condyle that is moving and allowing the jaw to take the path forwards, to take the path downwards, to take the path sidewards. So whichever movement that is happening when it comes to the movable part of the oral cavity or the stomatognathic system as such, the mandible, then it is happening because of the joint that is moving inside the glenoid fossa, underside the glenoid fossa. So the first thing is the movement of the condyle. And in simple words, the movement of the condyle inside the glenoid fossa is known as condylar guidance. So the guidance that is happening inside the joint, the posterior most guidance that is happening when it comes to the system as such in toto is known as your condylar guidance. That's the first factor when it comes to the Hanau squint. So when you talk about the condylar guidance, it is God created. So you cannot open up the skull and then you cannot change the condylar guidance that is there in a respective individual. That's the first point we need to understand. It's there already. We just need to capture it, what is there inside the joint, and we need to transfer it on to the semi-adjustable articulator so that we can program the next things. Whether you have the posterior teeth, whether you have the anterior teeth, whatever, the first factor that needs to be captured, the first thing that needs to be transferred onto the semi-adjustable articulator is your posterior most determinant. And that posterior most determinant is known as your condylar guidance. So that's the first part of Hanau squint. The second part of the Hanau squint is related to the posterior teeth. If you see here, this is the posterior section of the group of teeth that is present in the oral cavity. So when it comes to the posterior teeth, we have three things that we need to talk about. The first thing is your condylar guidance, the posterior most determinant, the middle most determinant. This is the posterior aspect, this is the anterior aspect, and this is the middle aspect. So when you talk about the middle aspect of the stomatognathic system, we have to talk about the occlusal plane, we have to talk about the compensatory curves, and we have to talk about the cuspal inclines. So when the wax mock-up or the wax-up is done on a semi-adjustable articulator, when we send it to the lab, see, the lab guys have to concentrate on these three things in between. So this is in our hands, in the operator's hand. The operator has to take the horizontal condylar guidance reading, program it on a semi-adjustable articulator, send the semi-adjustable articulator to the lab. And now what lab has to do, lab will concentrate on the middlemost portion or the posterior teeth as such. Lab will design the occlusal plane, lab will concentrate on the compensatory curves, and lab will concentrate on the cuspal inclines. So all these things are done on a wax up on a semi-adjustable articulator, and then they send us back. So when we provide the models that are mounted on a semi-adjustable articulator in centric relation in a particular vertical dimension, and we give it to the lab technician builds up these wax patterns on the semi-adjustable articulated mounted casts and sends us back. So this is in the lab's hand. So I'm just trying to simplify what is there in our hands and what is there in technician's hand. So this is in our hands. We have to just capture, put it onto the semi-adjustable articulator, and this is in the lab technician's hand. And what is the anterior most portion that we need to concentrate on? That is the driving factor for any kind of restoration. If you see this anterior portion that is there in the circle, this portion is related to the anterior teeth. So if you don't have anterior teeth, what does it mean? It means that your posterior teeth and the joint which is there behind the anterior teeth are actually going for a task. If you don't have a driver in a car, then what happens to the car? The car is not being oriented in a particular direction. It loses its way and the whole system collapses down. The same way, the driving factor for any kind of stomatognatic system is your anterior teeth. So if your anterior teeth are not designed well, if your anterior teeth are not prepared well, when it comes to the wax-up or when it comes to the final restorations, then the whole stomatognatic system fails as a unit. That's why the anterior teeth are very, very important when it comes to a full mouth rehab. And what is happening with the anterior teeth? The moment we close the jaw in static occlusion, what is static occlusion? When we open and close, this is known as static occlusion. So when we open and then close in maximum intercuspation, the posterior teeth are touching against each other and the anterior teeth as well are touching against each other. This is not like complete dentures in full mouth rehabs when it comes to the fixed restorations. What I have been trained, what all of us have been trained in the colleges is that in complete dentures you have overjet and overbite. So you need some space in between the anterior teeth. When it comes to complete dentures, we usually don't give a contact. We give 0.5 millimeters at least as an overjet and overbite according to the recent concepts when it comes to the complete dentures. But when it comes to fixed restorations, when it comes to your natural teeth, you should have a contact in the anterior teeth region as well. But the intensity of contact, should be lesser than the intensity of the contact when it comes to the posterior teeth. That's the whole idea of mutually protected occlusion. What is mutually protected occlusion? One hand is being supported by a, when we shake hands, it means that we are mutually protecting each other. In the same way, inside the oral cavity, the posterior section is helping the anterior section, and the anterior section is helping and guiding the posterior section. They're mutually protecting each other. That's known as mutually protected occlusion. So in static, what is happening? The posteriors are taking more load. Why? Because the posteriors are multi-rooted usually. The posteriors are straight inside the sockets. They're not inclined. They're not proclined. They don't have an angulation when it comes to the sockets. They're straight inside the sockets. So whatever force is falling on the posterior teeth, it's going down in a straight direction. The compressive forces are always helpful to the teeth, whereas the axial or the tensile or the oblique forces are harmful. So on the posteriors, what is happening is their loads are compressive. They're not tensile. They're not oblique. So as long as the loads are compressive, as long as the socket can take up the loads, as long as the roots are multi in nature, they are good to go to accept the forces. Whereas anteriors are single rooted. They are not straight inside the sockets. They are slightly proclined inside the sockets. So when the intensity of loads that fall on the anteriors is more, then the anteriors give up. They flare up more. They tend to create a lot of spacing in between themselves. A lot of diastema starts creeping in. So the intensity of the anterior contacts should be less and the intensity of the posterior contacts should be more, in simple words. So now what is happening? In static occlusion, the posteriors are helping the anteriors in a simple way, that the posteriors are taking more loads and the anteriors are taking less loads, but there is a contact still. Why there is a contact, I'll explain you in the next slides. So this is the posterior picture, this is the anterior picture, just to understand that we need to have contacts in the anteriors also, but the intensity of contacts should be lesser than the intensity of the contacts in the posterior region. When mandible comes forward, that is known as dynamic occlusion. So in static occlusion, the mandible is not moving. It is just opening and then closing down. So this is static, that's it. But when it comes to the dynamic, what is happening? The mandible is coming forward. From the static position, it's moving. That is known as your dynamic occlusion. It could be straight, it could be side. There are two kinds of dynamic motions that happen with the mandible, which is the mobile part. One is straight protrusion and other one is your late protrusion. The late protrusion could be right, the late protrusion could be left on each side respectively. So what should happen now when it comes to the protrusion? As I said, in static, I already have contacts in between the anterior teeth when I close down my mandible onto the maxilla. When I start moving my jaw forwards, because there are already contacts here, the jaw moves forwards and then downwards along the palatal inclines of the upper anterior teeth. This movement that is happening between the maxillary and the mandibular anterior teeth, in simple words, is known as anterior guidance. So in straight protrusion, you should have an anterior guidance that is the movement of the mandibular anterior teeth across the palatal inclines of the maxillary anterior teeth, which causes a posterior disclusion. This is an important point. There should be a posterior disclusion. How much is the posterior disclusion that we need? It should be immediate and it should be progressive. So the moment I start my mandible, I start taking my mandible forwards, you should have an immediate disclusion that sets in the posterior teeth, and it should be progressive as the mandible starts going forward, forward, forward to probably till edge to edge or crossover. You should have a progressive posterior disclusion that is happening. Why should we have a progressive disclusion when it comes to the posterior teeth? Just imagine if there is no disclusion that is happening when the anterior teeth are touching against each other, and now the mandible is moving forwards in dynamic protrusion. If there is no disclusion on the posterior teeth, the posterior teeth are still rubbing against each other when the mandible is moving forwards. And as long as the posteriors are rubbing against each other when the mandible is moving forwards, there are three things that might happen. Number one, there might be an excessive wear of the posterior teeth because of the frictional contact that is happening in between the maxillary and mandibular posteriors. Number two, the muscles that are surrounding the stomatognathic system in that area might become stressed, because as long as the posteriors are rubbing against each other, the elevator activity increases in the stomatognathic system. So as long as the elevators are active or hyperactive, then it takes a toll on the the equilibrium that exists inside the stomatognathic system. Third point, the joint, the temporomandibular joint, also goes for a toss because the posteriors are nearer to the joint, and as long as the posteriors are rubbing against each other, the force is falling on the muscle and on the joint as well. So it is not only disturbing the posterior teeth anatomy by wear, it is also disturbing the muscle and the joint that is there in the stomatognathic system. That's why we need to have an immediate and progressive disclusion so that there would not be any posterior interferences, there would not be any wear of the posterior teeth, muscle is not getting hyperactive, and the joint is also happy in its own space. So if we take care about this factor, this is known as functional equilibration. Why? Because the lower anteriors are traveling against the palatals of the upper anteriors and helping in function. So the anteriors now in protrusion are helping the posteriors in dynamic protrusion. Whereas in static occlusion, the posteriors are helping the anteriors. So in dynamic protrusion, the anteriors are helping the posteriors. If you see this picture, you will see one thing that is being highlighted, that only one tooth is in contact and rest of all other teeth are out of contact. This is also harmful. So when I say that the anteriors travel against, the upper anteriors, it doesn't mean that one tooth should travel and disclude all other teeth posteriorly or anteriorly. As much as possible, we should concentrate on anterior group function. So what is anterior group function is, either two teeth should travel against two teeth, or three teeth should travel against three teeth, or four teeth should travel against four teeth. So when it comes to the centrals and laterals, respectively, they should travel against each other, or at least three in a group, or at least two in a group, but one as a single unit. If it's traveling against the upper upper anteriors, creating a posterior disclusion, then either of these teeth might go for a toss. Either this will wear off over a period of time or might become mobile, or this might become periodontally unstable over a period of time. So we should make sure that we have a group function when the anteriors are traveling against each other in anterior protrusion. And now what is the next movement that is there? That's your lateral protrusion. What is lateral protrusion is when we move the mandible sidewards within the envelope of function. What is envelope? Envelope is a boundary in simple words. So when I open close, when I move forwards, when I move sidewards, the envelope that is happening, it's the boundary that is happening is known as envelope of motion or envelope of function accordingly and respectively. So when I take the mandible sidewards, towards the right if I take, then what all teeth should touch and what all teeth should not touch. Usually, normally, when it comes to the mutually protected occlusion, it's the canine guided occlusion that is taken as a norm, as a standard. So if your canines are periodontally strong, then what happens when the mandible moves sidewards, the whole load is being taken by the canines. So the canine will travel against the canine in the upper. The rest of all other teeth inside the stomatognathic system should exclude. Whether it is on the working side, whether it is on the non-working side, the rest of the teeth should not participate in the travel. They should be out of occlusion. This is known as canine guided occlusion. But sometimes we encounter that the canine might not be periodontally strong. The canine might be periodontally weak. The canine might be absent sometimes. You might have an implant in the canine. Then you might have to take the support of the premolar. First premolar sometimes, first and second premolar sometimes, first, second premolar, and the mesiobuccal cusp of first molar sometimes. Suppose you have an implant and you have given a prosthesis over an implant in the canine region where the canine is missing. And usually we take the first premolar into consideration and we give a partial group function. It's called partial because I'm not taking the complete group into consideration. Sometimes there would be periodontal instability that is existing inside the oral cavity. Canine might be periodontally weak. The first premolar might be periodontally weak. The second premolar might be periodontally weak. The first molar might be strong. So that time I take till the mesiobuccal cusp of first molar and then distribute the stress amongst all the teeth in the group. This is known as group function, full group function. So partial is only taking one tooth probably. If I am weak, then I might ask my neighbor who is there, support me. If my neighbor is also weak, then I have to go for another neighbor and tell, support both of us. So that's how we need to spread the contacts just to make sure that there is uniform distribution of stress in the lateral directions. If you give group function when the canine is strong, then what happens? You are allowing the system to take a lot of tensile stresses, lot of oblique stresses. So what is happening now when I'm doing like this? It's hitting the upper teeth. So when there is a lot of tensile stress that is happening or the oblique forces that are falling on the upper teeth when I'm doing like this, then again the same thing might happen. There could be wear of posterior teeth. There could be a muscle hyperactivity. The condyle which is coming down especially on the non-working side, which is nearer to uh, the condyle which is coming down, that might go for a toss. So all these things might happen when you take group function into consideration when the canine is periodontally strong. So when canine is good, take canine as the guidance and give a canine guided occlusion. If not, then think about group function. When it comes to the natural teeth or when it comes to the fixed restorations over natural teeth. But when it comes to the implants, full mouth implants, because you don't have natural teeth there, you have implants that are spaced there are uniform spaces in between the implants that are placed inside the oral cavity, you might have to go for a shallow group function in cases of full mouth implant reconstructions or rehabilitations, because in implants we need to distribute the stress, in simple words. So in order to distribute the stress, we go ahead with group function. We don't take only the canine guided occlusion in that scenario. So we're not talking about the implants as such, but what in natural teeth and fixed restorations when it comes to the full mouth rehabs, we take canine guided occlusion either on the non-working side or on the working side as the guide if the canine is periodontally strong. If not, you can take a call of either partial group function or a full group function as I explained just now. So if you see in this picture, there's a group function. So what do I say to the patient when I see something like this? First, I would evaluate and see if there are any signs and symptoms. If the patient is happy over a period of 10 years with this group function without any kinds of signs and symptoms, then I would not actually wake up a sleeping snake. It's sleeping, let it sleep. I would not take a stick and then hit it. It might hiss back again. So I would not disturb such patients where you don't have signs and symptoms inside the oral cavity, even though there is a group function when it comes to the lateral movement. At the max, what I would tell the patient is to be alert. Come to me after 6 months, let me see. Come to me after 1 year, let me see if you have any signs. If you tell me any symptoms, let me hear from you. And then yes, we'll take a call. But as of now, from the past 10 years, if you don't have any problem, if you are good with this, then it is known as adaptation. That is something which is wonderful that happens inside the oral cavity. It also pays a cost sometimes. So when I say wonderful, it doesn't mean that it is wonderful all the times. But yes, when it does not disturb the patient, it is. We don't change it. If we change it, what is happening is I'm creating something which was not there before. So that is known as positive occlusal awareness. So I am creating an awareness inside the oral cavity where there is already an adaptation and everything is going according to one sequence. Now I disturb the sequence. What happens? There is an awareness that is created. That is known as positive occlusal awareness. And now the system goes for a toss. There would be an imbalance inside the system. Now the problems start, coming out. So as long as you don't have any signs and symptoms inside the oral cavity, please do not do any changes, but yes, keep a check on the patient. And in case you see any signs and symptoms, you can start off by telling the patient that we might have to change the group function into a canine guided occlusion by any one of the approaches. Let it be a selective grinding, let it be an additive, let it be in a subtractive kind of equilibration, whatever, ortho or prostho, whichever kind of equilibration we select, we will change the group function into canine guided occlusion in such cases. So here also in this picture, if you see, there is a group function. So as long as you don't have signs and symptoms, stop there. Yes, if you have any signs and symptoms that are appreciated, then yes, you can definitely go ahead and tell the patient. So in simple words, this is your anterior guidance. We're not talking about the lateral as such, but when it comes to the lower anteriors traveling across the upper anteriors, is what happens. This is in static, this in mid static, and this is in complete protrusion, edge to edge. And now when you see such picture at end to end bite, you must have a posterior progressive, immediate and progressive disclusion that is happening inside the oral cavity. So by incorporating this kind of functional anterior disclusion guidance inside the oral cavity, we are going to protect the posterior teeth, we are going to protect the muscle, and we are also protecting the TMJ. Okay. By saying this, I would also tell you that the anterior guidance is not dependent on the condylar guidance. They're independent factors. if you take the condylar guidance, it is completely an independent factor. So it is not dependent on anything. It's already there. We just need to capture it and then put it on an articulator. But here, when it comes to the anterior guidance, we might have to customize it, because lot many patients might not be having an anterior guidance, might be having a disturbed anterior guidance, or might be having an anterior guidance which is wrong or which is pathological. So we might have to customize it in the anterior restorations when it comes to full mouth rehab, so that we can incorporate all these things what I have discussed till now. The posterior disclusions, the immediate and posterior progressive disclusions, the canine guided occlusion, all these things. We might have to customize the anterior guidance and then probably develop the wax patterns and then final restorations when it comes to the full mouth rehabs. So how do we customize the anterior guidance is the next topic that we need to discuss about. So when we talk about customization of anterior guidance, the first thing what we need to remember is that we need to develop matrix on the anterior teeth. When I talk about matrix, it's not the movie matrix I'm talking about. It's the envelope that I'm talking about. A matrix consists of the anterior portion, the incisal portion, and probably a palatal portion. When I say anterior portion, it is usually the labial or the buccal aspect. So we have to concentrate on three aspects of the anterior temporaries when we are customizing the anterior guidance. The first thing that we need to concentrate is on the buccal aspect or the lower aspect, the labial aspect. The second thing what we need to concentrate is on the incisal aspect. And the third thing we need to concentrate, that's the most important for the anterior guidance, is the palatal aspect. Only if your palatal aspect is good, then the anterior guidance also that follows forward and downward movement would be good. So that is how we need to customize. We need to customize each surface. The labial first, the incisal first, and the palatal next, according to few rules, according to few standardization points. We will see how to customize the anterior guidance by preparing a matrix of the functional anatomy of the anterior teeth. Let's take this case as an example. So this case was having a repeated dislodgement of the anterior two teeth, the anterior two crowns, not the teeth, pardon me. It's the anterior two crowns that used to repeatedly dislodge when it comes to this patient. So when the patient used to come with the crowns in the hand, the first thing what I evaluated when it came to the dislodgement of the crowns was if there was a good biomechanical preparation of the tooth structure, number one, because that's the primary retention, whatever. We don't consider the luting cement or the luting agent that goes inside the crown as the primary retentive mechanism. No, that's your secondary retentive mechanism which helps in the retention. The primary retention is always the tooth preparation. How well you have prepared according to the biomechanics. So first thing what I evaluated here was the tooth preparation. The tooth preparation was fine enough by some of respected colleagues. The crowns used to dislodge. So the second thing what I was thinking about was occlusion. Because the luting agent is the final thing for me. If these two things are okay, then yes, I might probably think about the luting agent as well. If there was any temporary luting agent that was used before, should I change it to a definitive luting agent? But yeah, that's the last thing that I would think about. Here, the second thing what I was thinking about was occlusion. Probably there was an interference in the anterior crown area palatally, which used to dislodge the crowns repeatedly. And yes, so what I did, I checked it with an articulating paper, which articulating paper number, which color, I will explain, you will discuss that once the slides go forward. But I checked and yes, I found that there was an interference, there was a high point when it came to the anterior crowns. That was probably the factor that caused the dislodgement of these two crowns. So what I did, I removed them. I made arbitrary splinter temporaries. When it came to temporaries, we can always splint and then we can harmonize the anterior guidance. But when it comes to the final crowns, it has to be single crowns. Usually we don't give splinted crowns as long as there is no indication for it. So there are different indications for it. That's a different topic. Let's keep it aside. But as far as the slide is concerned, I made a splinter temporary. The first thing what I concentrated was on the lower incisal edge position. That is the most important thing. If your lower incisal edge position is not seen, and then we are doing changes on the upper anteriors, it doesn't make any sense. We need to first figure out that the lower incisors are good enough for the travel that is happening with the mandible. If one lower anterior is above the plane and one lower anterior is below the plane, you cannot get uniform or harmonized anterior guidance that you expect. So you always have to see for the lower incisal edge position. That's the first thing. So I looked out for the lower incisal edge position. There was some discrepancy which was corrected by minor ortho and composites. And once that was done, then I started customizing the anterior guidance. I started preparing the metrics for the functional anatomy. So the first thing what I told was your labial anatomy or the buccal. When it comes to anteriors, we usually call it as labial. When it comes to posteriors, we call it buccal. So the first thing what I want to concentrate on is the upper half of the labial surface. If you see here, the labial surface is designed into two halves, the upper half and the lower half. This is the upper half and this is the lower half. So the upper half usually should follow the maxillary bone anatomy in the anterior area. So if this is the inclination of maxillary bone anatomy in the anterior area, the upper half also has to follow that. I cannot keep the upper half probably somewhere here or probably somewhere down here. It has to follow the maxillary bone anatomy. So what does it help? And how does it help? It helps in giving an emergence to the crown. So it is basically about the aesthetic part. When we are preparing the matrix on the labial side, the upper half is basically for the emergence, for the aesthetic component. So we prepare the temporaries, we either trim or we either add some material here so that we make sure that this is going in junction with the maxillary bone anatomy in the anterior region. Once that is done, then we concentrate on the lower half when it comes to the maxillary temporaries. The lower half is usually prepared or customized according to the lip closure path. Suppose I am closing my lips. The path should be very smooth. Both upper and the lower lips should close against each other without any kind of restriction or resistance. So that is known as your lip closure path. So we either add material there in the lower half, or we either add some material there, remove some material there on the lower half, so that the lip closure path is good, is smooth. And once that is done, we check for the phonetics, the F and V. So when I say F, what is happening? The inner 1 million border of the lower lip is touching the incisal edges of the upper anterior teeth. So just say F, you will see that the inner 1 million border of the lower lip touches the inside. If it's not touching, then yes, you might have to change the incisal edge in such a way that it touches the inner 1 million border of the lower lip whenever the patient says F or V. These are phonetics which are used to prepare the matrix when it comes to the incisal edge. So the labial surface, first we see the upper half, whether it's following the maxillary bone anatomy. The lower half, lip closure path, it has to be smooth. And then the incisal edge for phonetics, which is your F and V sounds. Once we prepare this, once we harmonize or customize this, if you see here it was touching the outer border of the lower lip, then customized in such a way that it touches the inner vermilion border of the lower lip. Once this is done, we are done with the labial as well as the incisal surface of the matrix. What is left out now? Now comes the most important aspect, because right now till here we have been concentrating on the aesthetic and phonetic part. We have not concentrated on the functional part when it comes to the rehabilitation. The functional part starts on the palatal surface. You don't do the function on the labial or incisal, right? So I don't move my mandible like this from the labial. I don't move my mandible on the incisal. I start moving my mandible from the palatal. That's where your function starts. So the palatal surface is important for the functional aspect of the matrix when it comes to the preparation. So on the temporaries, what we do, we first find out the centric stop where the lower anteriors should rest on the upper anteriors in a very mild intensity contact. We would not give a heavy contact, whether it is anterior natural teeth, whether it is your restorations, because we don't want that. It should be very mild. Only when the patient compresses, bites in, you should have that touch of the anteriors, and there should be a smooth movement of the mandible forward. That's known as grazing contact. To be very specific, it has to be a grazing contact. So we first see for the centric stop. Where should we give the centric stop? The centric stop has to be given in between the incisal 2/3 and the cervical 1/3. So if you see here, I've written it as centric stop. This is your incisal 2/3 and this is your cervical 1/3. This is where we incorporate that stop of the mandibular anterior teeth when it comes to the maxillary palatal of the anterior teeth. So we create a centric stop here, we create a centric stop here, and those centric stops should be equal to the centric stop here and here. Then only it becomes harmonization of anterior guidance. If I create more centric stop, more intensity of centric stop here, and intensity of centric stop here is more, and you don't have stops here, then yes, these will take up more force, and again there will be a problem of dislodgement of crowns. So you need to harmonize now in such a way that you have equal distribution of stresses on the anteriors together as a group. Then it becomes harmonization of anterior group function. So one centric stop here, one centric stop here, and then probably the same centric stops somewhere here. And when it comes to the stops, usually we don't put it on the center because the travel happens like this. It goes on towards the mesial of the anteriors. So we don't create the movements here in the center. That's how it happens when it comes to the normal functional movements. So if you see here, yeah, I think there was some problem with the slide. Now it's corrected back. Yeah, good to go. So now here, when you see the centric stop, from here the movement starts. So the mandibular anterior teeth should follow the movement and then probably go on to the incisal edge. That's how it has to go from the centric stop to the edge to edge contact. And that is known as that travel that is happening by the mandibular anterior teeth when it comes to the maxillary palatals is known as your anterior guidance. So the anterior guidance happens here. It's somewhere here. So all we are talking about now is about this part when it comes to the palatal aspect that starts from the centric stop probably till your incisal edge. This is what we have been talking about as a function when it comes to the anterior guidance. Now, if you see here, there is one mark here, there is a very mild intensity point here, and there is a point here. So it is still not harmonized. There is a heavy point somewhere, there is a very mild light intensity point somewhere. So we don't have equal distribution of stress still. So that is actually the problem that was happening before, that was leading to the dislodgement of crowns. So we need to now make sure that there is equal distribution of contacts everywhere. Usually when it comes to the anteriors, the articulating paper that I would use is your 12 micron or your 8 micron articulating paper. Usually I use 12 micron to check the contact, that's all. It's called a shim stock. It does not color anything. It does not mark anything on the teeth. It is just to make sure that you keep a shim stock and then you tell the patient to close and then pull it to see the resistance, if you have good contact or no. But when it comes to the marking, usually I take 8 micron paper and fine tune the occlusion in the anteriors. So 8 micron, you can use two colors. For centric, you can use your blue or black, and for eccentric, you can use your red. There is no hard and fast rule that you have to use red for this and black for this. No, it is just to make sure that you have a distinction between the two movements. In static, you have one color. In dynamic, you have another color. So it's up to your convenience which color you want to use. You want to use blue or black or red, whichever. But make sure that you have two colors that would distinguish two kinds of movements, if it's static or dynamic. All right. And the forceps which is used to hold the articulating paper is known as Miller's forceps. Kindly invest this into your practice so that you don't use this normal tweezers to hold the. Don't use carbon papers also again. That is a no. So if you see here, by equilibration, I am trying to achieve equal or the uniform contacts on the anteriors. If you are getting on canines also, it's not an issue. Let it be there. It becomes a group function. If not getting on canine also, then yes, you might have to probably again equilibrate and then get it on the canine. So don't worry if you're getting the dots from the canine to the canine. It acts as an ideal group function that is taking the stress in the anterior region uniformly. So as I started equilibrating, as I started adding and removing some material from the temporaries in the center, I'm trying to achieve uniform ideal centric stops on the anterior teeth. And then this is because of the movements that is happening. I would still try to fine tune it and then get a very, very minimal intensity contacts. And now if you see, there are two marks that is happening now on the anteriors. There's one mark in one position, another mark in another position. What is this? So when the patient goes into supine position, when the patient is in the supine position, the mandibular posture would be different from the patient when in alert feeding position or an alert position, in a straight position, sitting posture. Why? Because when the patient goes into supine, the mandible slightly goes back, and when the patient comes forward to alert feeding position, the mandible slightly comes forward. So you have two different positions happening on the anterior palatal surface, and those two different positions that are happening on the anterior palatal surfaces will lead to long centric. What is long centric is when the patient in supine, it goes into one position. When the patient is in alert position, it goes slightly forward, probably 0.5 millimeters slightly forward to that position which is in supine. And these two positions will be separate as I have shown it in the picture. If I don't join this point and this point together, then it becomes two different points on the crowns. When the patient is sleeping, there will be force in a different point. When the patient is sitting, there will be force in a different point. So I make it a freedom point there. So what I do, I take a bird and then I join these two, which are like 0.5 millimeters away from each other, and create a freedom there for the movement. This freedom which is happening is known as freedom from centric, which is happening in the anterior palatal surfaces of the crowns. So we incorporate a feed of freedom from centric in this way. I take a burr and then I just remove this portion which is now free for the jaw to move and to be free either in supine position or in alert feeding position. That is known as your freedom from centric, which is also known as long centric. Now once that is done, then I check for the group function in the protrusion as well as your lateral occlusion. In protrusion, if I'm getting all lines starting from the canine till the canine anteriorly, then I would probably try to decrease the intensity of the lines, but I would not eliminate the lines because it's group, it's acting as a group. So don't bother. If you're getting lines all over, let it be there. Don't intentionally create lines. Okay, let it be there, let it be there. So we don't disturb them, but we try to decrease the intensity of the lines. That's known as fine tuning. And then in lateral occlusions again, if you're getting only on the canines, it's fine enough, the lateral movements. If you're getting on the anteriors also, let it be there, don't remove it. Let it be an anterior group function again. But if you're not getting it, if you're not getting these lateral lines on the anteriors, only on the canines if you're getting, don't intentionally create them. Let only the canines take up the stress. So if you're getting it naturally on the anteriors, let them be there. If you're getting it on the canines, fine enough, let them be there. So don't intentionally create on the anteriors as such. So if you see this picture, you'll understand what I've just explained. This is your labial surface. That's following the anatomy for aesthetic part. This is your lip closure. This is your F and V for the phonetics. And this is the centric stop. And from here, we are actually doing all this harmonization and customization aspect when it comes to the functional anatomy. So now I have prepared a matrix when it comes to the labial, incisal, as well as the palatal surface. Okay. Usually the cervical 1/3 is for phonetics again. The restoration thickness should not be more in the cervical 1/3 for TDS sounds. You can remember it as tax deduction system. If you forget it, TDS. So when you say TDS, the tongue usually goes and falls in that area. So if your restoration thickness is more in that area, you might miss upon the TDS. So we usually keep it less. Now my functional matrix is ready. When it came to the temporaries, I'm doing everything on the temporaries which are luted inside the oral cavity. Now I place my finger and I check if there is any fremitus positive there. So when I am doing these movements, I should check for the movement of the teeth also, if the fremitus is positive or negative. Now, once my matrix is ready, I take a Facebook transfer. I make an impression of the maxillary arch with the temporaries inside the oral cavity. I mount the maxillary cast with the Facebook record on a semi-adjustable articulator. I take the impression of the lower cast as well, and then I mount the lower cast in centric relation or equilibrated maximum intercuspation, whichever. If your maximum intercuspation is equilibrated already, which is equal to centric relation, you can just take the bite, the squash bite, the interocclusal bite, and then you can mount it. If not, take it in centric and mount it. And once the mounting is done, I adjust the protrusive horizontal condylar guidance according to the patient. And then on the incisal guide table now, whatever I have done on the temporaries inside the oral cavity, I'm going to capture everything on the incisal guide table. So this is known as customized incisal guide table. So now how do I customize it? You take the incisal pin probably 0.5 millimeters away from the platform of the incisal guide table to create a space for the material there. You put some pattern resin in the material space here. You close the incisal pin back onto the incisal table. Now, on a semi-adjustable articulator, for the maxillary member to move forwards and backwards, you have something which is known as centric latch. So the centric latch, if you open it back on any kind of semi-adjustable articulator, here I am showing a CSA, but if you take any kind of semi-adjustable articulator, you will have a centric latch. You have to open the centric latch for the maxillary member of the articulator to move forwards, backwards, and sidewards for the dynamic movements to happen on a semi-adjustable articulator. So you remove the elastic, you open up the centric latch now, and now on the pattern resin, I will be moving the maxillary member of the articulator in forward and lateral occlusion movements. So when I'm doing this, what am I capturing in the pattern resin? I'm capturing this travel that is happening by the lower anterior teeth against the maxillary upper anterior teeth. And what are these maxillary anterior teeth? They are the temporaries that have been harmonized inside the oral cavity. That impression I've taken, that cast I've taken and mounted. So when this movement is happening on the articulator against the palatal surfaces of the cast, I'm actually capturing this movement in the pattern resin here in the form of incisal pin when I'm moving it. So when I'm moving the incisal pin anteriorly, posteriorly, sidewards, if you see here, I have captured a Gothic arch tracing like an arrow. So this is protrusion, this is lateral occlusion. So I've captured the palatal anatomy of the maxillary anteriors in the pattern resin that I've placed on the incisal gate table. This is known as customization of anterior guidance from the oral cavity in the form of temporaries on to the cast, maxillary cast in the semi-adjustable articulator, and from there on to the incisal guide table in the form of pattern resin. So we are following a sequence now to customize the anterior guidance. And now this is known as customized anterior guide table. And now how will it help? You take this customized anterior guide table, send it to lab. Lab will keep this customized anterior guide table on the semi-adjustable articulator and develop the wax patterns, palatal surface, according to this guide table. Now lab will put the guide table and he or she will move this incisal pin forwards, backwards, sidewards, and then on the wax patterns palatal surface, the lab technician will develop the anterior guidance. This is how we start with harmonization of anterior guidance, and then we end up with customization of anterior guidance and development of anterior guidance in the wax patterns. And the wax patterns come to us, we make a putty index, and then we start off with the next procedures, temporization and the final crowns in full mouth rehab. So this is a simple explanation of what is anterior guidance, how is anterior guidance helpful, and how do we have to capture and then probably customize and harmonize and customize the anterior guidance when it comes to full mouth rehabilitation cases. Let it be a single crown, let it be a 2 crown case, or let it be a group case where you have full mouth rehab case. We need to follow this sequence and then end up the case. Last point before I end up the presentation, in few cases you might not have anterior guidance. In class 2s where you have more of horizontal overlap. In class 3s where you have edge to edge or cross bites, you will not have anterior guidance. In open bites, you will not have anterior guidance. So as I said, until and unless you have signs and symptoms, you need not change it. If you have any signs and symptoms, there will not be any adaptation that is happening inside. So you need to reorganize the occlusion. Otherwise, conform to the occlusion that is present, which is already adapted inside the oral cavity. I hope this presentation was helpful in a way, and then thank you for giving me this opportunity.
Hello, am I audible, Anmol?
Yes, you're audible.
Yes, sir. Yes, thank you so much, sir, for sharing your vast knowledge and experience and giving us the clinical tips and tricks to deal with the anterior guidance. There are a lot of comments on our Facebook post. People are loving your seminar, and we have a few questions to take on. So should we begin?
Yeah.
Dr. Shilpa wants to know, what is an occlusal equilibration in simple terms?
See, occlusal equilibration in simple terms is making the maximum intercuspation inside the oral cavity equal to the centric relation inside the joint. That's it. So we have different methods of occlusal equilibration. You can either do selective grinding, you can either go for orthodontic treatment or prosthodontic equilibration, or finally a surgical one.
Yes, sir. Thank you, sir. Dr. Sabina wants to know, can you please revise which occlusion to be given where? Like where to give an implant protected occlusion, where to give canine guided occlusion, where to give a group function, like that.
When it comes to the fixed restorations, especially when it comes to natural teeth or crowns on uh, fixed crowns on natural teeth, we go for usually mutually protected occlusion. When it comes to the static occlusion, we have posterior more contacts and anterior less contacts. In dynamic protrusion, we have posterior disclusion, and on the late protrusion, we concentrate on canine guided occlusion. That's what we usually do it when it comes to mutually protected occlusion. But when your canine is not stable, when your canine is not periodontally stable or missing, or if an implant is there, you either go for partial group function or full group function, where you involve other teeth. When it comes to implant rehabilitation as such, the full mouth implant rehabilitations, we don't concentrate on canine guided occlusion because we don't want to take only one implant into the consideration and put stress on the implant. We try to distribute the forces. So we go for usually shallow group functions there and not steep ones.
Yes, thank you, sir. So next question is from Dr. Arjun Narang. He wants to know, what would you prefer, CSA 400 or CSA 600 for FMR cases?
Doesn't really matter, because when it comes to the Bennett, you see the difference between CSA 400 and 600 is you have an additional Bennett feature when it comes to the CSA 600. When you consider CSA 400, you don't have it. But usually when we either program a CSA 400 or 600, we are not going to take lateral records in any of the articulators we're using. We're fixing the Bennett at 15 degrees and then we are proceeding with the case. So either you have CSA 400 or CSA 600. As long as you have a semi-adjustable articulator, it's good to go.
Go on. Yes, sir. So next question is from Dr. Rohini. Sir, if there's an open bite along with spacing in anteriors, in that case, if we correct it with the prosthesis and then there is a problem, what will happen to the patient? Like pain or pressure, what will happen?
It depends. That's what I said. If it is adapted and if the patient has no signs and symptoms, then you might have to do an aesthetic correction and leave it. You don't usually bother about the functional guidance there, as long as the occlusion is adapted. If there is a sign and symptom already, if the patient is having muscle pain, if the patient is having TMD, whether it is muscular or intracapsular, you need to evaluate the case accordingly and then proceed. So changing the functional aspect when it comes to the palatal surface completely depends on the signs and symptoms of the patient. Otherwise, you can just do the cosmetic correction and then leave the patient.
Yes, sir. Thank you so much, sir. So next question is from Dr. Aman. So ideally, what sequence should we follow? Either first anterior guidance or the posterior guidance?
See, usually when it comes to temporization, we usually concentrate posterior aspect first. We go for posterior temporaries. We make sure that the vertical dimension is stable. Whatever the vertical dimension we have decided on, we make sure that the vertical dimension is not lost anywhere. And then we come to the anterior temporization. But when it comes to the finals, because we already stabilized the system in one particular vertical dimension, we start with anteriors. We go for anterior guidance first, and then we go for the posterior stops next. So temporization, posterior, anterior, final anterior, posterior.
Stop the slide more severe than the where
Your
that
video
is
stuck,
noticed
Pratik.
on the inclines that causes the displacement. RCP.
Can you just get back? I couldn't.
Yes,
Repeat
sir.
it once again.
Yeah, I think there's some problem with my net.
Now it's okay.
Why? Yeah. Why is the wear on inclined surface that stop the slide more severe than the wear that is noticed on the inclines that causes the displacement?
See, if you're talking about the anteriors, see there is
RCP, sir. RCP.
RCP. So there is something which is known as the hit and slide that happens. So when there is a hit in the posterior area in centric, okay, there is a slide in the anterior direction. So when there is a posterior hit and an anterior slide that is happening, usually you see a problem in the anteriors more than in the posteriors, because when there is a hit, there is a slide that is happening in the anterior region. So the anteriors are going for a toss. There is a hit in the slide in the anterior that is causing the flaring of the anteriors and diastema in the anteriors. So usually when you have this hit and slide that is happening in the posterior area, rather than the posteriors going for a toss, you will see more of flaring in the anteriors and diastema in the anteriors. So in such cases, you might have to correct the hit and slide. Not all the slides are harmful. Let me tell you, not all the slides are harmful. Probably a slide which is more than 1.5 millimeter or 2 millimeters is known as a harmful slide. And if you have any cuspal incline contacts, they are deleterious contacts. They are harmful contacts. They produce a lot of tensile stresses onto the teeth. And that's why you see a lot of occlusal wear that is happening.
Yes, sir. So thank you so much. So last two questions. If tooth do not have vertical height and the crown is to be given, what can be the option, sir? If tooth does not have the clinical height is small, so what can be done in
See,
such
the
cases?
first option you can think of is a bonded crown. If you don't have the height, clinical height, you cannot give a biomechanical tooth preparation there, to be very frank. So you might have to assess the amount of enamel that is present on the tooth, circumferential or peripheral enamel. If you have good amount of peripheral enamel, you can go for a bonded crown. Number two, you can concentrate on secondary retentive features. You can either go for a proximal box or grooves that you can incorporate, whether it's a single tooth or multiple teeth that are involved in the bridge. You can either go for crown lengthening procedures according to the periodontal status of the tooth, or you can go for subgingival finish lines and then increase the clinical crown height. So you take an option, you take whichever suits according to the clinical scenario, and then you can proceed.
Yes, sir. So thank you so much. Next, the last question is from Dr. Rohini. So how to correct if the patient is complaining about the pain? So in FMR cases, do you prefer going for RCTs of all the teeth or likewise? So what is your opinion on this?
No, I would not prefer intentional RCTs in full mouth rehab cases. According to me, I don't do it. Vital tooth preparation is always something which is good. If you prepare biomechanically, then you will definitely not have a problem on a longer run if you are sticking on to the basics. Number two, root canals are preferred only if there is any kind of periapical or perioperiapical pathologies that are linked with each other. Intentional root canals are preferable only if you have probably any traumatic incidents that happens on the teeth, iatrogenic defects, sometimes iatrogenic trauma, or if you have supraerupted teeth which cannot be corrected by ortho or which cannot be corrected by any other means of treatment modalities, then we go for root canal treatments. Otherwise, no.
Yes, sir. See, thank you so much for answering all our doubts and queries, sir. It was a pleasure to host you and have you on the board from Team Cynodent. So thank you so much. I call
Thank you,
Dr.
Pratik.
Anmol for concluding this session. Dr. Anmol.
Thanks, sir, for giving his valuable time to us and delivering such an informative lecture. And I would also like to thank the audience for being with us today. And lastly, I would thank Dr. Pratik and Shweta for hosting this session and all the members of my team Cynodent.
Thank you, guys.